So now let's see if we can figure out how and why the extraocular muscles move the eyeball the way they do. This is an important little diagram here. This shows you the testing of the extraocular muscles in isolation. First off, from the primary position, the lateral rectus abducts, abducts, the medial rectus adducts. However, you have to regard this kind of like a stick shift in a car. To test the superior inferior rectus, in this case, you first have to initiate abduction, abduction by the lateral rectus, and if the eye is abducted by the lateral rectus first, then the eyeball, or the angle of gaze, is aligned with the angle of pull, or the vector of pull on the eyeball. So in the abducted eyeball, the superior rectus leads to pure elevation, and the inferior rectus to pure depression. Similarly, if we had the eyeball adducted by traction from the medial rectus first, the inferior oblique would lead to pure elevation due to its distal attachment on the eyeball, and the superior oblique would lead to pure depression. As standalone instructions, this probably does not make a lot of sense. So let's see if we can add in a few more helpful diagrams and delve a little bit deeper. Because once everybody's had this important aha moment, it'll be much easier. Okay, so let's remember. We can move the eyeball in 3 different axes. We can move it around the vertical axes, that is abduction and adduction. We can move it around the anterior-posterior axes, which would be intorsion and extorsion, or lateral and medial rotation. And we can move it around the transverse axis, that will just be looking up and down, or elevation and depression. Here comes a really important concept to understand. Although the eyes are looking forward most of the time, like they are in this image, they are located in these pyramids that are not completely straightforward. No, they are actually at an angle. Okay, so the axes of the orbit diverge at 45 degrees. All right, the axes of the lateral wall diverge from each other at 90 degrees. If the eyeball is looking straight forward and we have muscles attaching on the surface of the eyeball, but at an angle back here, you can imagine if I pull here, it's not going to lead to a pure elevation and depression, but it's also going to include, for instance, a little bit of abduction or abduction, and possibly also extorsion. So if we have a look at this image here, from the primary position, we can see if I was to pull on the superior rectus, the action elicited from traction on the superior rectus is going to be, of course, elevation, but due to the angle, the diverging of the optical axis with the axis of the orbit, in addition to elevation, there's going to be adduction and intorsion. If we think about the traction of the superior oblique here, see the superior oblique gets redirected through the trochlea. So if I pull in this direction, you can see here the vectors, the force vectors of pull with the gaze straight forward. Well, if I have the gaze straight forward and I have traction elicited from the superior oblique, it's basically going to go down and out and in. So the superior oblique from the primary position will lead to intorsion, depression, and abduction, whereas the inferior oblique with a gaze in the primary position is going to abduct, so abduct, elevate, and extort the eyeball. In this position, there are only 2 muscles that if they contract on their own, they're only going to lead to a single motion. And that's fairly intuitive because the lateral rectus just attaches on the lateral aspect of the eyeball here. If I pull here, it'll be pure abduction, abduction. And the medial rectus, if I pull towards the midline, it'll be adduction or adduction. If I try to coax a simple single movement out of any of the given muscles, otherwise I'm going to have to change the direction of gaze to align the optical axis with the axis of the orbit. And that would look something like this. Now imagine we have the eyeball first abducted by about 23 degrees, And look, suddenly we've aligned the axis of the orbit with the axis of the vector of the pull of the superior rectus. So now if I pull on the superior rectus, I have pure elevation. If I pull on the inferior rectus, I have pure depression. And if I have the eyeball adducted due to prior traction of the medial rectus, I'm going to have the inferior oblique lead to pure elevation and the superior oblique to pure depression. And it all is because of the angle of gaze and its alignment with, or its non-alignment with, the axis of the orbit. So if I add in this diagram as well, we can see the optical axis going straight forward when the gaze is forward or into the primary position. So if I go back a slide, you can see usually this is what the eyeballs are looking like, or what they look like, and that's the direction, the traction of the superior and inferior rectus, medial, lateral, and superior and inferior obliques are. However, let me switch over here. Now imagine I would first make the medial rectus pull. That means the eyeball would move in this direction towards the nose. Okay, at least the left eyeball would. And in that case, if I've done that, I would be able to have the inferior oblique lead to pure elevation and the superior oblique to pure depression. On the other hand, let me go back one more time here. If I was to pull on the superior rectus in the primary position, it is sure going to elevate, but not only elevate. It's going to elevate, adduct, and rotate the eyeball medially, so intort. If I want to have a pure motion elicited from the superior rectus, I just need to turn the eyeball a little bit, abduct the eyeball, so that the optical axis is aligned with the orbital axis, like this, and then I would be able to have the superior rectus purely elevate and the inferior rectus purely depress. So if we go back to the other image, in clinical testing, to test the superior or inferior rectus or the inferior or superior oblique in isolation, we have to isolate them. And we test them in isolation by either using the lateral rectus first or the medial rectus first. This also means the abducens nerve, the one that innervates the lateral rectus, is fairly easy to test because you can test that just straight from the primary position. You say, please follow my finger or a pen light or something. You ask the patient to follow the pen light and move it laterally. And so, well, if I had it right here and I moved it over there, the right eyeball would be able to follow it, even if I had a paralysis of the lateral rectus in the right eyeball, because the medial rectus would be doing all the pulling. However, the left eyeball would not be able to follow it because the lateral rectus would not work. If I had a paralysis of the medial rectus, here or here, I wouldn't be able to elicit a deduction. So, in a nutshell, to do your clinical testing, you first ask the patient, look over to the side, then look up, then look down, or look towards the nose, or medially, of course, and then look up and down. This is how you can test the extraocular muscles in isolation. So, quintessentially, the take-home message is, because the apex of the orbit is placed more medially relative to the orbits themselves, the orbital axes will not coincide with the optical axes, as you can see in this diagram nicely here. So when the eye is in the primary position, as here, the superior rectus and inferior rectus will approach the eyeball from the medial side and not straight. So their line of pull, or their vector of pull, is going to be passing medial to the vertical axis. Hence, we have more than pure elevation or pure depression resulting from this. For both muscles, that means they have a secondary action of adduction. Also, because the superior and inferior rectus will extend laterally, they pass superior and inferior to the anteroposterior axis. That also gives the superior rectus a secondary action of medial rotation or intorsion. So, intorsion you can see right here. It's all color-coded for us here. And for the inferior rectus, that means it gets a secondary action of lateral rotation or extorsion. If we do direct the gaze laterally, as done here, the line of gaze coincides with the plane of the inferior and superior recti. So the superior rectus can produce pure elevation and the inferior rectus can produce pure depression. The superior and inferior obliques, if the eyeball is adducted, will be able to elicit a pure motion as well, which will either be depression for the superior oblique and elevation for the inferior oblique.